Hi, it's Dr. Centeno, and I'd like to talk to you for about 50 minutes or so about what is Regenexx and how we help patients avoid invasive surgery. So before we get started, any references to the Regenexx-C procedure, which is the cultured stem cell procedure that we no longer perform here in the U.S., actually refer to an independently owned and operated facility in Grand Cayman that we don't have any association with, that licenses that technology, and where our physicians can go time to time to see patients who require that more advanced technology. So what we'll discuss today: the basics of platelets and stem cells, who are we, interventional versus surgical orthopedics, where does Regenexx fit versus everything else, the basics of our procedure, what other types of procedures are being offered, and then we'll talk about really just some patient experiences and data for each body area, and then we'll wrap it all up. So the basics. We'll talk today about platelets, so it's important to understand that platelets are the thing that helps your blood clot. They also release growth factors that help healing. And consequently, we use platelet-rich plasma, which is concentrating those blood platelets to enhance tissue repair, as well as platelet lysate, which is stripping whole platelets of their growth factors to enhance repair. So those are two different things. Platelet-rich plasma, concentrated blood platelets; platelet lysate, more getting the growth factors out of platelets. And we'll talk today also about stem cells. So there are different stem cell types. You've got adult stem cells, which pretty much live in every single body tissue, and embryonic stem cells. And then more recently, there's been a discussion on induced pluripotent stem cells. So adult, embryonic, and induced pluripotent stem cells. These are artificially lab-created stem cells. Today, we're really going to be talking about adult. So what is an adult stem cell? The simple definition is it's a blank slate cell that's held in reserve in a tissue until replacement or repair is needed. So tissue damage happens, then the adult stem cell springs into action to try to repair the area. It can turn into a lot of different cell types, and it can orchestrate a repair response. So to use a construction site metaphor, platelets are like espresso shots given to workers to help them work harder and faster, whereas stem cells are this curious mix of a general contractor who can bring in other subcontractor type cells to do some of the work, but they can also turn into the bricks and mortar. So who are we? Well, you may have seen us on various news programs through the years. We've been on the doctors a few times, etc. So we've been out there for quite a while. And as a result, we're really the original orthopedic stem cell procedure. We've been doing this work now for about a decade, since 2005. We've treated thousands of stem cell patients with all types of tissue sources using same-day and cultured cells since that time. And to date, there's been about 11,000 Regenexx procedures, and we add about 2,000 orthopedic stem cell procedures a year to our clinical registry. We're involved heavily in bioengineering, in clinical research, laboratory research, and regenerative medicine. So quite different than your average medical practice who's involved using stem cells, in that we have a large clinical research team. We have a university-style lab where we perform our own basic science research. We treat patients and develop devices. So let's look at a 30,000-foot view of orthopedics and stem cells. And really the most important thing for us is this distinction between injection-based care and scalpel or surgical-based care, because we believe that all of this is rapidly changing as we speak and will change over the next 15 to 20 years. So surgical orthopedics, first off, is not doing so well. We've got big studies that show that arthroscopy for a meniscus tear is really no better than placebo or physical therapy. We've got other big studies showing that knee and hip replacement prostheses are failing, and they're really not giving patients the kind of relief that they would expect. And I've blogged on some of this in the past. We know that fusion for the spine overloads other joints, leading to quicker arthritis. We know that tendon and ligament surgeries like rotator cuff and ACL have turned out to have surprising failure rates. And what's even more surprising is things like ACL surgery often lead to early arthritis, regardless of whether or not the patient gets the surgery.
Because of biologics, orthopedics will become mostly percutaneous.
Poorly surgical orthopedics.
What do I mean by biologics? I mean mostly initially autologous biologics. Patients
offer a really
stem cells and
interesting opportunity.
I also
to
mean
move invasive orthopedics
biologics
towards needle-based
that
care.
will follow after that.
So if we look at surgery and injections, just 15 years ago,
other technologies
everything
that will
that
allow us to repair tissue. So if we looked at 2000 or the year 2000,
this year,
and surgical versus percutaneous, and what I mean by percutaneous is needle-based
the widespread use of platelet-rich plasma,
there really
and now stem
wasn't
cells,
much contest.
That many
surgery dominated
who would have gotten
what we
surgery
did in
no
2000.
longer get surgery.
And outside of some steroid shots,
patients that have severe
that were
tendinopathies
really
who
done
were
on the
previously
minority
getting
of
surgery
people,
in
there wasn't much
Achilles
being done through injection,
or
which is
tendinopathy
percutaneous.
at the elbow aren't
But
getting
by
surgery
this
anymore.
next year, that will actually have
if we
changed
look
quite a
at
bit.
Where this is
I think
going
we're
to
already
be
seeing
15
that
years
about
from now, we believe it's going to
of
flip.
all
We believe we're going
orthopedic
to see
interactions that
more
go beyond
injections
physical
being done in
therapy
orthopedic care
are turning into needle-based things,
far
like
less
platelet-rich
surgery,
plasma
simply
injections
based
for
on the
tendinitis or
possibilities
tendinopathy.
of
We're not doing
biologics.
many tendinopathy surgeries anymore.
So if stem cells allow for needles to do great things, how important is an accurate injection? Well, obviously, if you're going to be placing cells in an area of the musculoskeletal system to prompt repair, you want to make sure you're pretty darn accurate. However, that's usually not what happens. About half the time we see blind injections by physicians, and that means that they don't use any guidance, they just sort of inject by feel, and many times they don't get where they want to go, meaning that the cells don't get where they should go. And then we have low accuracy guide injections. The good news is that we are seeing more physicians using things like simple ultrasound guidance. The bad news is that most of these physicians using this technology aren't well trained enough to know, for instance, how to get cells into an ACL that's torn in the knee or a meniscus that's torn. They can just sort of get it someplace inside the knee. And then the minority of physicians use precise guided injections. And these physicians actually know how to get cells in specific areas. And that's really where Regenexx is focused. We're not doing blind injections. We don't do low accuracy guided injections. We're really focused on this precise guided injection. And it's one of the reasons why we turn down many, many physicians that want to do this kind of work, because they don't have the base training to allow this kind of expertise. So this is an example of a precise guided biceps superior labral injection. And this is just going to go round and round, but you can see here the needle coming off from this side. You can see the needle injecting right at the superior labrum. So rather than taking off this patient's biceps tendon and rather than doing a massive surgery trying to repair this, this is a patient who did quite well simply by getting a very precise injection of stem cells into the superior labrum. So in short, we represent a new medical specialty, interventional orthopedics. The concept that as biologics and delivery devices and methods continue to improve, most of orthopedic surgery will be replaced by precise needle-based procedures. And our goal is always to try to offer patients less invasive procedures to avoid the need for more invasive surgeries. So we use things like advanced ultrasound guidance and fluoroscopy to be able to make sure we can get cells in the right place. So let's now look at the 10,000 foot view, drilling down a little more. Where does Regenexx fit versus everything else is really a big question. Now, when we first started doing this work in 2005, there was no one else doing this. And right around 2010, we started to see a few other folks enter in doing this kind of work, and we were frankly happy to have the company. And this last year or two, we've seen an explosion in stem cell use by physicians. So it's important now to make sure that you understand where we fit within that explosion. So we're not a bedside machine, nor are we a weekend course. And what do I mean by that? Well, the vast majority of physicians that do this kind of work go out and purchase a bedside machine, and all you really need to know is how to push the on button. And there's positives. The positive is that it's very, very simple for the doctor. The negative is that it's not very flexible, nor is it very advanced. You really don't get to some of the concentration levels we can get to. So we're not that. And we're also not a weekend stem cell course. There are now many, many weekend stem cell courses that you can take. You can go out there and pay your money, and as long as you've got a driver's license and a credit card, you can get stem cell training. And we're not that at all. We're extremely selective about who we train. So we're not this, we're not that. So what are we? Well, in addition, it seems like we have lots of Regenexx emulators that pop up every day. And these are just a few that are out there. But basically what happens is these folks try to throw their hat in the ring. And again, we're happy to have the company as long as people understand that what we're doing is at quite a different level. And it all comes down to one of my favorite commercials of all time, this Wendy's commercials from the 1980s, the Where's the Beef? If you remember the three little old ladies and this one screaming, Where's the beef? And they're looking at the little patty and the big bun. And obviously Wendy's did this commercial to try to say, hey, we've actually got something different. And again, I would state that that's our mantra as well. And let's talk about that. So first, it's important to understand our process. So we first innovate in the lab, we then perform clinical research, we then track patients in the registry, we use data to guide treatment decisions, and then we publish what we think is important to publish. Obviously, not everything is so interesting, so what gets published is more what readers would consider interesting, more medical readers, obviously. So if we look at clinical research, we've got an awful lot of research that we've published through the years. We just had a hip paper accepted, and we continue to get research published. We've got the world's largest patient registry, bar none. There's no one that's tracking as many stem cell treated patients right now on the face of the earth for any indication as we are. And we also use big data biostatistics. Other clinics, not so much. There's really no one else doing this kind of stuff. Now, what's interesting is this costs a ton of money. And we spend a ton of money doing this stuff. And everyone else just doesn't do it. Why don't they do it? Because it costs a ton of money. And if we look at the world literature, the good news is that for bone marrow stem cell treatments in orthopedics, the world literature is getting quite mature. We see 5,000 patients have been treated and published in the peer-reviewed literature going back to 1997. And our research group has published approximately 1,457 of those 5,000 patients, or 29% of the world literature has been published by our research group. So we're very, very focused on publication, and we will continue to be, because we believe it's a very important thing for a new, burgeoning and very, very promising technology. So I'm going to highlight here our papers, and you can see our papers here in the mix of all the different papers that are out there. And if we look at who else is out there just practicing stem cells in orthopedics, and we look at the number of publications they've had, this actually does not include our hip paper up here. I didn't have a chance to add that in yet. And this is now unique patients treated. So to the extent that I could in some of these other physicians' papers, I tried to get to unique patients, not all patients published. And this number is now up to more than 1,000 for us once we add in our hip paper. But what you can see is that Felipe Hernigal has done a fantastic job of publishing, really the father of orthopedic regenerative medicine going back to the 90s. Jae-Woo Pak in Korea has done a great job. And then not much really has been published outside of that. And some of these names here you would think would do a lot of publishing based on their web presence, but they're really not publishing in the peer-reviewed literature or research. So when we look at lab research here, we've really got a university-style lab. What does that mean? We have a lab that is very advanced, and you wouldn't really be able to tell our lab from a lab that you saw in a university. And we have all of these toys, so to speak, because we're dedicated to improving what we do. So we have things like real-time PCR and fluorescent microscopy and ELISA and flow cytometry and now a fluorescence-activated cell sorter. And we have all of this. Again, these aren't the kind of things that you would find in any other stem cell clinic in the U.S. These aren't the kind of things that you would find in any medical practice in the U.S. And we use these things to advance what we do, and I'll talk about that in a second. As far as other clinics are concerned, not so much. There really isn't anyone else out there that's doing this kind of advanced basic science research as part of their medical practice using stem cells. So here's an example of how we can use stem cells to help develop new technology. So this is the second generation Regenexxx-SD-Plus. Basically, we asked ourselves about 2 years ago, how do we markedly increase the number of stem cells we can get out of bone marrow? Really, bone marrow isolation hadn't really changed much since the 1960s. So were there other ways that you could do it to improve the number of cells that you got? And if you did, would that actually correspond to better clinical results? So we looked at both of those things. We first developed this in the lab. We then looked at adding those additional cells into patients. So this is the old technique here, and this is the functional scale improvement. And you can see here with the new technique, we get a lot better or more function. And this is the pain improvement. So we get more pain improvement by adding in the more cells. And this is self-report percentage improvement, more percentage improvement reported by the patient. So this is how we were able to take something as simple as getting more cells, which turned out to be quite complex, and then correlate it to a clinical outcome and say, yeah, that's a good idea. We should keep doing that to better help our arthritis patients. So let's now talk about our stem cell procedure and the basics. So for platelet-rich plasma, we've been going through multiple advancements. We're now in our third generation, what we call super concentrated platelets. For platelet lysates, which is stripping the growth factors out of platelet-rich plasma. We're again on a third generation high growth factor platelet lysate, and we're working on fourth generation versions of both of these. For same-day stem cells, we are now at our second generation procedure, and then our licensed procedure down in Grand Cayman produces even more stem cells through culture. Again, that's being done by a company down there in Grand Cayman. For our stem cell procedure, the basics are pretty clear. We collect bone marrow aspirate from the back of the hip. We collect a blood sample. We then isolate the stem cells in the lab. We can inject the same day, or we can, the patient can be seen down in Grand Cayman, where that facility can culture their cells for 2 weeks to get more. It's important to note that that's not approved for use in the U.S. by the FDA. It is obviously approved for use in Grand Cayman by their Health Practice Commission. So isn't a bone marrow aspiration painful and awful? Now this is an interesting concept because most patients have this thing in their head where they've heard, gee, those bone marrow things, I think those are painful. So we actually asked 44 of our patients way back 6-7 years ago, and this is what we found. The vast majority of patients said that the bone marrow aspiration procedure was really no big deal. So let's look at the Regenexx treatment protocol for joints. This is, again, a very rough metric. Just to give you an idea, we have a pre-injection a few days before the stem cell injection, and that's really just a till the soil type injection. We then have a stem cell injection where we plant the seeds, so to speak, to use a farming metaphor, and then a post-injection where we fertilize. So till the soil, plant the seeds, and fertilize. As far as our advanced same-day stem cell isolation protocol, as I said, we've added in a new wrinkle that allows us to get a lot more cells out of the same bone marrow sample. So what other types of stem cell procedures are being performed for orthopedic injuries? Well, it's important to kind of look at what else is out there. The biggest other things that are out there for orthopedic injuries are same-day fat stem cell treatments, amniotic stem cell treatments, and the Regenerative or Orthokine procedures out of Germany, which are also offered at a few places here in the US. So the first issue is, again, people have this in their head that somehow a bone marrow procedure is awful. I have to tell you, having done both, a bone marrow aspiration procedure is much more like just a blood draw, whereas a lipo-suction procedure is a pretty violent, aggressive procedure. And actually, the data on complications bears that out. For a bone marrow aspiration procedure from this huge UK registry of 20,000 procedures, extremely low complication rates. But for a liposuction fat harvest, the lowest complication rate I could find with the most minimal liposuction, which is not what's being done for about half or more of the patients getting fat stem cells. They're getting a more aggressive liposuction, but that's 1.5% compared to 0.07% complications. So as you can see here, a bone marrow procedure is far safer than a liposuction procedure. So there's another question that's out there. Doesn't fat have a bunch more stem cells than bone marrow? The biggest problem with that argument is head-to-head comparisons of fat stem cells of bone marrow stem cells when used for orthopedic conditions heavily favors bone marrow. And our SD-Plus procedure can now get many, many more cells out of bone marrow. How about amniotic stem cells? This has been a hot topic lately, mostly because it's easy for doctors. Doctors can just go ahead and purchase this stuff off the shelf. They can pull it off the shelf when they want it. They don't have to really go through the hassle of taking stem cells. And a good friend of mine who's a sales rep calls this the baby juice sales pitch. But because basically that's what this stuff is. If it's a liquid, it's amniotic fluid from inside the amniotic sac. You can also purchase amniotic membrane, which is micronized or chopped up finely. The big issue with this is it's not really a stem cell procedure. It contains no stem cells, just amniotic tissue from the amniotic sac or birth membranes. And there's really no data on whether or not this works. So there's tons of information, 5,000 patients published going back to the 90s for bone marrow. There's a little bit of information published on fat, but about a 50th of that published for bone marrow and orthopedics. And there's really zero data published on amniotic tissues. Again, they're not really stem cell procedures. So doesn't Germany have some great things to offer? I've heard about this Regenerative Orthokine thing. And it's interesting. Regenerative or Orthokine is a natural serum-based anti-inflammatory shot. It's not a stem cell or regenerative medicine procedure at all. And if you talk to US vets who have used this for quite some time, it lasts for about 6 to 9 months. And so it's basically just a natural anti-inflammatory shot. This is what Kobe Bryant got. And as you see, their own research doesn't show great things versus placebo. There's barely any difference here versus placebo. So for knee arthritis, this really isn't a fantastic option. It's just a natural anti-inflammatory shot. So now let's talk about patients and data. And the reason why I break this up like this is because most patients really want to hear about how other patients who had a similar condition to theirs fared. They don't necessarily sync real well with data. Now we collect data because we think it's important. And we do have some patients, we treat a lot of physicians and healthcare providers and PhDs who are very interested in delving into the data, and we're always happy to do that. So tonight I'll present patients and data so you can get really a sense of what we have on both sides. So who are our patients? Weekend warriors, active elderly, professional athletes, young athletes, and traumatically injured people. So first, let's talk about safety. Safety is a big deal. First question to ask is, if we look at the other treatments that are out there outside of Regenexx, how much safety data has been collected? And the answer is not much. On the other hand, we've published a lot of safety data. This is actually a paper that was published by a group. This is a group out of Europe who actually took our information and looked at it independently and decided that the cultured procedure that we licensed down in Grand Cayman was as safe as hyaluronic acid injections or knee gel shot injections. We didn't really know these guys at all. In fact, they just sent me an email out of the blue, said, "Can we have your data?" I said, "Sure," and it went from there. And then we've published multiple other things about the safety of our different procedures. We also put things online like this. So if we look at the information that's currently online on 1,100 patients, these are the same day Regenexx-SD patients, you can see here the vast majority of patients had zero complaints at all. And this little slice of pie here really looks at any kind of complaint, whether the patient said, "I had a cold afterwards," or the patient said, "I feel sick," or whatever. That's a complaint. Then of those complaints, these are the things that were considered more serious complaints, and none of which turned out to be related to the procedure, but that's just based on the nature of what the patient said. So they might have said something like, "I had a heart attack 3 years after the procedure," when they were high risk for heart attack at the time they had the procedure. And these are categories of adverse events that are here. So highlights: pain and swelling about 4%, clicking, popping, catching the joint 0.6%, no infections, cardiac, renal, blood work, neurohematoma, neoplasm, all unrelated or self-limited. So those are the highlights, and you can get more information by downloading that infographic that's online. And our next safety paper will be on about 2,300 patients receiving about 3,000 orthopedic stem cell procedures. We're actually sending that out to independent reviewers, so it won't be us that performs the final adjudication of anything that could be considered an SAE or a serious adverse event. And it'll be the largest stem cell paper published in humans to date for any indication, whether that's orthopedic or otherwise. Here I'll review now knee, hip, shoulder, foot, ankle, hand, wrist, and then spine. I'll do it in that order so you have some sense of how to fast forward based on what your interest is. So again, we'll start with knee, go to hip, then we'll go to shoulder, foot, ankle, hand, wrist, and then we'll talk about and finish up with spine. So what do we treat? In general, we treat things like arthritis, meniscus and labral tears, ligament tears like ACL, MCL, and tendon issues like rotator cuff. We don't treat other medical conditions. We don't treat spinal cord injury. We don't treat diabetes. We don't treat neurologic conditions, ALS, etc. We're focused simply on these orthopedic problems. So if we look at the knee, we'll start with a patient story. This is a young elite basketball player at the high school level who had a knee meniscus tear. Her father recognized that if she had surgery at her young age, she was going to end up with arthritis at an early age. So he wanted her to avoid surgery. We were able to help her avoid surgery. This is her making a big shot in the championship game after we treated her. And this is just a mom who wanted to get out there and race in a triathlon. And she wasn't able to do it. She got stopped by her knee. She was told she was eventually going to need a knee replacement, but we helped her get through all of that, again, just with an injection of her own stem cells and not needing a big knee surgery. And this is a gentleman who's an NFL football player who was gracious enough to allow us to talk about him. We treat athletes, but most of them are not interested in having everyone know their business with regard to their bodies. But this gentleman was really at the end of his career. All he wanted was another year. He was told that he was washed up and couldn't get that other year because of his physical condition with his knees. We were able to get him that extra year with the Houston Texans, and he was very thankful for that extra year to play one more year in the NFL than he could have otherwise. Now let's talk about some data. This is about 1,000 procedures, and this is percentage improvement. Patients reporting 50% or greater improvement, the percentage of patients reporting greater than 50% improvement. This is the mean improvement of all patients. And you can see in general, patients get about 50-60% relief when we're talking about all patients. And again, this is all patients, 1,000 patients. So there are patients in here that got 100% relief. There are patients that didn't respond at all. These are the averages when we look at going through 4 years. Also recognize that as we get to these two time points, 3 years and 4 years, it gets pretty tough to follow patients for that length of time. So these two time points could be artificially inflated because some of the patients dropped out by that time and we weren't able to contact them. This is now pain and function data. So this is the 1 through 10 pain scale showing a decrease over time over the first 3 years, which is what we would expect to see if patients were getting better. And then their functional scores improving, so their function increasing over that same time. And this is 710 patients. It's also important to note that all of this data I'm showing you is multi-center. What does multi-center mean? Multi-center means that it's collected at 20 or more sites, not just one, not just Colorado. You should probably also note that we have a knee osteoarthritis randomized controlled trial ongoing in Chicago. So that's a free of charge trial if you meet the inclusion-exclusion criteria. And you have to agree to be randomized for that. Some patients are fine with that and some patients aren't. And speaking of Chicago, this is some data that was collected by Mitch Scheinkopf in Chicago, who's our affiliate there. And what Mitch did is he looked at knee replacement data that he had collected previously on his patients versus their Regenexxx-SD stem cell information. So this is the before function score. And you can see here that the Regenexx patients are a little bit more functional than the knee replacement patients at the start. And then the after function score, they both improve about the same. And then the before assessment score and then after assessment score. So pretty good considering that some of these patients underwent basically what amounts to a knee amputation and then insertion of prosthesis, and the other patients just underwent a series of injections with their own stem cells. We also look at our database frequently to try to see if we can look at trends that'll help us make clinical decisions. So, for instance, women have a slightly better outcome than men. Not huge, but slightly better. It is statistically significant. There isn't an association between age and outcome, meaning we had thought that older patients wouldn't respond as well. That does not appear to be the case. There isn't an association between body weight and outcome. We had thought that heavier patients might not respond as well. That doesn't appear to be the case. There isn't an association between arthritis severity and outcome. We had thought, for instance, that patients with more severe arthritis might do poorer, but that's not the case. Now, there is an association with many joints and a less robust outcome. So patients who have multiple complaints of joints, let's say a shoulder, a knee, a hip, and an ankle, those patients aren't going to do as well with Regenexx-SD procedure of their knee. So we try to counsel them and make sure that they know and they understand that. There have also been claims that adding in fat stem cells can dramatically help knee arthritis patients, and our data doesn't support this, interestingly enough. We actually looked at this issue. What would happen if we took bone marrow plus fat stem cells? Would that dramatically improve outcome? And just talking to the folks that were doing this out there, they all claimed it dramatically helped their patients. But when we looked and compared head-to-head with bone marrow only, there wasn't a statistically significant difference here. And in fact, we've just published a paper on this showing that there was no big difference between fat stem cells plus bone marrow and bone marrow cells alone. Now we'll switch gears for a second, slightly, still talking about the knee, but talk about the Regenexx ACL procedure. That's simply treating patients with ACL tears and precisely placing those stem cells within the ACL tear. This is a college football player who allowed us to talk about him. And the bottom line with this guy is that he injured both of his ACLs. His ACLs were treated with the Regenexx procedure, and he got back to playing football much, much quicker than many of his colleagues who had more traditional surgery, who also injured their ACLs. This is actually his pre-stem cell picture here. You can see this very, very wavy appearance of his ACL. And that's not normal. This one looks more normal. This is post-stem cell, and you can actually see nice straight fibers on his MRI. And these are different patients here. If we go backwards on this one, you can see this is what a normal ACL should look like, and you can see this is what his ACL started like before we injected it. The interesting thing about these pictures is that this isn't supposed to happen. ACLs don't repair on their own, or at least that's the common wisdom. So if we look here at another ACL, we see this ACL that has two blunt ends here, and then again where those two blunt ends come together. So interesting MRI findings. We just submitted a big paper on this. It was provisionally accepted with some small changes, so hopefully that'll get out and published here pretty soon. Now let's talk about hip arthritis. These are patient stories. This is a dancer who had a hip labral tear, and she was nice enough to send us this wonderful picture of her dancing in Germany. She's with a troupe that goes around the world, and we were able to help her avoid a big surgery. As you might imagine, for a dancer, the concept of a huge big surgery is not something that's going to work. It's really going to take her out for a year or more, and probably she would lose her position. She obviously didn't have to do that. This was a very precise injection of her own stem cells into her hip labrum. With regard to hip arthritis, this is just a gentleman here on the right who wanted to go back to riding his bike with his buddies, and we're able to help him do that. He had more severe hip arthritis. Now, one of the things to recognize about our hip arthritis data is that in general, hip arthritis patients don't fare as well as knee arthritis patients. And that's something we've seen for a long time in our data. So if we look at 1 month, 3 months, 6 months, 12 months, 18 months, 24 months, 36 months, what we're seeing here is the good news is that for the Oxford Hip Score in 370 patients, we are besting what's called the MCID, which is the line at which, above which you're doing something and below which you're apparently not helping the patient very much. So that's the good news. But again, just recognize that hip arthritis patients in general, when compared head-to-head to knee arthritis patients, tend to underperform. And these are the things we've seen by looking at our registry, that range of motion appears to be associated with lesser outcome. We haven't found any decreased likelihood of success based on arthritis severity, sex, or patient weight. We have seen in and out associations, meaning that this is an association that we've seen come and go based on the size of the data sets. And more recently, in almost 400 patients, it went away. So what that means is that there seems to be some effect of older age and arthritis, but as we collect more data, that effect is washing out. So it may not be a true effect. It may just be that we didn't yet have enough information on all of that. So how does a hip replacement compare to Regenexx-SD? You can see there the before hip score, the after hip score, before and after range of motion. The most interesting thing is that, again, the hips here didn't do as well as when we compared against the knee replacements. Having said that, this is pretty good compared when you compare an injection to just or to a huge surgery where there's an amputation of the joint. And there do appear to be differences here when we look at the same day and culture procedure. For knees, these differences aren't as stark. So for knee patients, there's some difference, but not a huge difference. But there appears to be a bigger difference when we look at the cultured versus the same day with hips. So let's now talk about shoulder patients. These are some success stories. This gentleman was a two-time Olympian who had a massive rotator cuff tear. We were able to, well, he had the first rotator cuff tear before we saw him. He was treated actually by our LA affiliate, Dr. Bletcher. And when Dr. Bletcher first saw him, he really didn't think that he would be able to help this gentleman based on the size of his re-tear. But he said he would try, and this is what he told us after we injected his shoulder. So he did really, really well, despite having a very big tear, and despite our doubts that we could help him. And this is a Pilates instructor who was looking at shoulder labrum surgery. And in fact, I showed you her x-ray before getting injected. She was the labral tear that was getting injected. So you can see what happened to that particular patient. And for general shoulder arthritis, this is about 100 patients here. This is the mean improvement of patients. You can see fairly high success rates out to 2 years, which is pretty consistent with what we see with shoulders. Shoulders do very well. If we look at just pulling out the patients who only had rotator cuff issues within that group, still very high rates of improvement for rotator cuff tears. And here's some before and after MRIs. You can see here a huge tear in the rotator cuff, and then the after picture showing no tear. You can see here a nice defined tear in the rotator cuff, and then the after picture showing no tear. So let's now switch gears to foot and ankle. Again, patient stories. This is just a woman who wanted to walk on the beach at her beach house. She had been told that she needed an ankle fusion or an ankle replacement and didn't want to go that direction. And this is a younger patient who was told they needed an ankle fusion and did, again, quite well. As far as Achilles tendonitis is concerned, we were asked by the Cayman government to treat one of their Olympians, and we were able to get her to be able to run her own invitational and do quite well. This is her shot after winning that invitational in Grand Cayman. We also treated a stress fracture on her, and as well as the Achilles tendon. Now let's look at foot and ankle, Regenexx-SD versus C. So this is the same day versus the cultured. Not a huge difference between these two. There might be a slight advantage to cultured cells, but same day cells seem to be hanging in there pretty good. Most of these patients are tibio-talar or main ankle joint arthritis. Now let's look at hand and wrist. These are two patient stories. This is a journalist who could really hardly do much. You really take for granted that if you can't use your hand, you really can't do much in life. And this is an interior designer. And this one was treated with same-day cells and this one with cultured cells, just to give you an idea. And there does appear, while there wasn't a big difference in knee, there doesn't appear to be a big difference in ankle. There does appear to be a difference here between same-day and cultured cells with regard to CMC thumb joints. So it's an interesting thing to look at. We've published a paper over on this side, and we'll be publishing some of this research here in the near future. Now let's talk about spine, and then after spine we'll wrap this up. These are just some patient stories here. This is a woman who wanted to go and dive the world's coral reefs and actually plant new coral to kind of save coral reefs. And she had this dream her whole life. And then when she got to retirement, she couldn't do it because of her back. And frankly, if she had a huge back surgery, she knew she wouldn't be able to do it. So we were able to just use her own platelets through the regenerative or the Regenexxx-SD-D procedure to help her get back to doing that. And this is what she is a picture of her that she sent to us. This gentleman actually had SI joint pain and nerve pain going down his leg, and he has a really harrowing story. If you go to the blog, you can see his story. He's an elite climber. He basically was climbing in Nepal and basically had to rescue some people off the mountain. And after all of it was done, he shook his head and said, gee, I wouldn't have been able to do that without those Regenexx injections. So it's an interesting story to read. And this is just a woman who wanted to avoid getting a steroid epidural. And she hadn't done well with steroid epidurals, but we're able to inject the growth factors from her own blood platelets. We also routinely treat neck and upper back pain as well as headaches, so not just low backs, so that you understand that. And we've got a very broad spine care spectrum. We can use the patient's own growth factors. We can treat degenerative disc disease. We can use same-day stem cells for a very specific type of patient, or cultured stem cells for a very specific type of patient. So this is an example of some of those platelets. This is a third generation platelet lysate, where we compared that procedure to the standard procedure of a steroid epidural. And what we saw here was a change in the functional rating index. More is better. So this is the steroid epidural side, and this is the Regenexx side. This is the steroid epidural side at 6 months, and this is the Regenexx side. So you can see there some significant differences between the two when one is compared head to head. This is actually just an MRI from a car crash victim who had a problem in their upper back. You can see here big facet joints that are pressing on the spinal cord, and then much lesser or facet joints that are not quite as big, and much more room around the spinal cord after the procedures were performed. And this was the Regenexxx-SD-D procedure. This is a patient who also got the DDD procedure, a huge herniated disc here, and then that sort of goes away over time. What's really interesting about this is that we didn't go into this patient's disc. We did everything but go into this patient's disc. So this was a less invasive procedure than one where the disc is entered. This is a patient where we did go into his disc. We had treated him for many years with platelet epidurals. He had done quite well. And then he stopped responding after he had a new injury. And it turned out he had a tear in his disc. So we did feel it was important to go into his disc with his own same-day stem cells. And he really did quite well with that procedure. He just pinged me recently for an update on this and is still doing quite well. And then can we get rid of a persistent disc bulge with specially cultured stem cells? And this information is on the website if you want to look at it. These are all patients who really fail epidurals. They fail even platelet epidurals, and they have persistent disc bulges pressing on nerves, and some of the things we've been able to accomplish with injecting specially cultured cells. This procedure has actually been taken over by a company which is pushing the FDA rock uphill here in the U.S. They've just submitted a pre-IND filing on this. And in the meantime, it's still offered down in Grand Cayman because it does involve culturing cells. So to wrap it all up here in just a few minutes, to learn more, spend some time watching our videos. I really enjoy working with the animator, making these, trying to take very complex things and make them simple. You might want to read our book. It's been downloaded an awful lot of times. This is actually, these numbers are relatively low because this information is a few months old. But it really can give you a good sense of how we conceptualize problems. And I find that patients that read the book are much better patients. They know what's going on. Also consider our stem cell supplement. Most supplements really are just someone got together, they pulled some research out of PubMed, and the research studies may or may not have anything to do with the kind of patient being treated, but they threw some supplement ingredients together and threw it out there. We had the problem of constantly being asked by our patients, what supplements should I take to help my stem cells? And I got tired of going to the National Library of Medicine, pulling papers that really didn't apply to their clinical situation. So we did a year worth of lab research with human mesenchymal stem cells, looking at things like cartilage production, proliferation, whether those stem cells could withstand a bad chemical challenge similar to a bad arthritic joint. And we came up with our own supplement with ingredients that we knew would work at least in the lab. So what to look for in a clinic, a protocol that's been used thousands of times, obviously imaging guidance to take and place cells like we've discussed, and specific outcome research on the specific protocol. And this is something, a bait and switch I see an awful lot. The provider doesn't really have any specific research on the specific protocol they use, so they just basically throw a bunch of research on the website that has nothing to do with the protocol that they're using. A clinic that's constantly innovating, collecting and publishing data, and then actually puts things out there in the peer-reviewed literature. When you should run, be very careful with clinics that will treat erectile dysfunction, neurologic disorders, MS, and arthritis. Again, very, very concerned when I see those kinds of clinics. A clinic that promises extremely high success rates that seem too good to be true, long on success stories, short on data, claims that a doctor took a stem cell fellowship. We actually have fellows that we bring in for training. It takes a year for us to train a fellow. What I'm talking about here are people that claim to have a stem cell fellowship, but they really just took a weekend course. The physician is not an MD or a DO. We're seeing naturopaths and chiropractors now getting in to this whole thing, and which to me is a little bit frightening when it comes to some of the complexity of these injections. And obviously the clinic just opens, but somehow claims to be an expert in everything. So here's our Regenexx provider network. We actually have a few more sites right now than this. These are physicians who we screen very, very heavily. This is not an any willing provider network. In fact, we have a very, very low acceptance rate in this network. We have to make sure that these physicians have a base level of training in precise X-ray or fluoroscopic or ultrasound guided injections before we'll agree to train them. So in conclusion, Regenexx isn't magic stem cells, it's advanced and precise interventional orthopedics. We've been doing this longer than anyone else in the US. We have more published and online registry data than anyone else. We spend more resources stacking the deck in your favor, and we have more treatment options. So thank you so much for spending a few minutes to watch this. And if you have any other questions, Our website contains thousands of pages, so you can probably find the answers there or through staff. Thank you very much.